So Dr. Eneyni is joining us today to discuss presenting features of multiple sclerosis. So Dr. Eneyni, what are some presenting features in multiple sclerosis?
Well, MS can present in a variety of ways. Patients sometimes can have one or more symptoms. One of the more common symptoms of multiple sclerosis is sensory change. In about 40% of patients that present with a symptom of multiple sclerosis present with numbness. And the numbness can involve loss of any of the sensory features of their bodily function. For example, they can lose capacity to sense light touch, they can lose capacity to sense pain and heat or cold sensation. In addition to that, patients with multiple sclerosis sometimes present with an extra sensation. So they can present with too little sensation of something, or they can present with extra sensation. It's called a positive sensory phenomenon. That can look like a tingling or numbness or even burning sensation. And that can involve any parts of their body, really. Usually with multiple sclerosis, though, the involvement is more than a small area. So it's usually the whole arm will be numb or the whole leg will be numb. But it could be in a smaller portion than the whole extremity. It can also involve the trunk. That's a common area that it can involve, especially in spinal involvement in multiple sclerosis. And it can also involve the face as well.
And how do you differentiate between these symptoms?
Well, that's a good point. First, there are the description. There's the description of the patient. What part of the body did it start at? How did it progress? Is there a negative phenomena, meaning are they sensing less than they should, or are they sensing more than they should? Is there pain with it? And the neurologist could also differentiate the location of the distribution of the sensory loss. There is a type of sensory loss called dermatomal distribution, which is a involvement of one particular dermatome or a portion of the nerve. If that is the case, usually it indicates that it's actually the nerve, not the central nervous system that's involved. So if somebody has a pinched nerve in their back, for example, they would have a type of sensory loss that's usually different than the sensory loss that a patient with MS would present with. Sometimes it's an overlap, but overall that is a safe bet.
Okay. And are there any visual symptoms?
Visual symptoms are also very common in multiple sclerosis. There is a common visual complaint called optic neuritis, and those patients present with pain on eye movement and visual loss. Now, the visual loss usually affects one eye. So if they close one eye and then the other, then notice that one eye is involved, usually. And the visual loss can be severe, so they can lose complete or incomplete vision, and that's, of course, is very noticeable to patients. They will come running to the eye doctor or to the ER. Or it can be very subtle to the extent that some of them may not notice it until they come to see the neuro-ophthalmologist or the neurologist. And it can be simply loss of capacity to differentiate shades of gray, or to differentiate colors. So they may or may not notice it, but the optic neuritis can be severe. They can lose a lot of vision, and it's usually preceded by pain on eye movement. Not in all cases, but in some cases. And the good news is that even though the visual loss may be severe, there is a very high chance of them recovering their vision in up to 6 months. Now, there are a lot of patients who have optic neuritis who don't have MS, but the risk of developing MS after you have optic neuritis is very high. There was a large study done here in the United States called the Optic Neuritis Treatment Trial, or ONTT, and they used certain medications like steroids on those patients, and they found that the chance of you developing multiple sclerosis in about 10 years after you have an optic neuritis, the chance is in the 30%. Less if you don't have a lesion on MRI at presentation. So if you had an optic neuritis and your neurologist did an MRI of the brain and it was negative, normal, then the chance of you developing multiple sclerosis is about 20-some% after 10 years. If you had a lesion, the chance is in the 40s up to 50% chance of developing multiple sclerosis. So, the average rate is in the 30s, less if you have a negative MRI at presentation, and higher if you have a lesion on MRI at presentation. And in future conversations, we'll be talking about when to treat in that case. Do you treat if you have an optic neuritis treatment, or if you have an optic neuritis according to the optic neuritis treatment trial, would you treat or not treat if you have a lesion or don't have a lesion? So there's some So decisions have to be made at that point whether what type of treatment, if any, do you need at that point.
Okay. And what about motor symptoms?
Well, motor symptoms are also common, a little less common than the sensory symptoms. Of course, they can involve the motor function of the eyes. So in addition to the visual loss that a person can have, they can actually have problems moving their eyes. So they can have double vision, or they can have a disorder called internuclear ophthalmoplegia. It's a big term for problems moving the eyes in a conjugate way, in a coordinated way. So one eye would move quicker than the other, so the patients will feel kind of funny. So that's actually a problem of moving the eyes, not the problem of the sensation of the eye itself. So that's a motor deficit in a way. There's also, of course, a motor deficit in the arms and legs. They can have difficulty moving the arm or leg. And they can have, just like with sensory symptoms, they can have too little movement, so they can have weakness, or they can have increased tone, or spasticity we call it, or stiffness. They feel stiffness of the legs. Sometimes that is the presenting symptom. I remember a patient that we saw here who had problems running away from a car that was approaching him while he was crossing the street. That's how he noticed that his legs did not move. He tried to run away from a car, and then the legs just got stuck to the ground, and went to see his doctor, and he was referred here. And we found on presenting day, on the day he arrived, was spasticity in the legs, was too much tone in the legs. And then we did some studies, and eventually that person was diagnosed with MS and is doing very well. But so increased tone in the lower extremities or even upper extremities can be a presenting symptom as well.
And what about some cognitive deficits? Are there any there?
The cognitive deficit is very common in multiple sclerosis. It's often underlooked by patients themselves because the cognitive deficit or the memory deficit that they have or the analysis deficit that they have in their brain is very insidious. It starts very slowly, and they're usually young people with a lot of reserve. In other words, they have a lot of cognitive capacity still, and so they lose a little bit, they're able to compensate for it. But often they are this is brought up to them at work or at home, that you're a little forgetful, you can't concentrate. But if we did neuropsychological testing on them, half to three quarters, 50 to 75% of them will have some sort of cognitive deficit. And actually that can be debilitating at some point, and some of them had to become disabled because of the memory deficit that they have. So that is common.
And so would you say that that may lead to more patients having depression with this then?
Depression is also very common in multiple sclerosis, and that becomes a complicating factor because, as we will see later in upcoming videos, that some of the medicines that we may use to treat multiple sclerosis have a side effect of inducing depression. And already up to 3/4, if you read some studies, up to 3/4 of patients who have MS have some degree of depression. You always worry about which are the candidates to receive those types of medications that can induce more depression. And you also have to worry about the living situation of that particular individual. Are they living alone? Do they have a good social support around them? Risk of suicide is high in the ones that live alone. And also remember that MS by definition affects usually younger people. So these are people starting their life, they're just engaged to be married or just had a child, and you know, you're not giving them a death sentence, but you're telling them you have a chronic disorder you have to see a doctor for frequently. So they tend to be depressed just situationally because of having to see the doctor frequently. But MS by itself can induce depression symptoms, and that should be asked and addressed by the neurologist or treating doctor.
Okay. And what about urinary problems with multiple sclerosis?
Urinary problems are also common in multiple sclerosis. They often have trouble emptying their bladder. Either from increased tone in the bladder, that the bladder can dilate to hold the urine, or the bladder is unable to push the urine out when the person urinates. So there will be a residual urine in there often. And the residual urine that sits in the bladder can become a nidus, or can become a little medium in which bacteria can grow. As you know, the urine of the human, it should be clear of bacteria. But if it sits in the bladder and there's retention of urine, that can grow some bacteria, and an infection can trigger an attack of multiple sclerosis. So it becomes an extra important thing to notice if the person has a bladder emptying problem. And there are certain medicines and certain procedures that we can do to alleviate that. First, we'll have to diagnose it. Usually a trip to the urologist would be the start, and then they would do some tests called urodynamics to see how the bladder dilates and empties, and they compare the bladder function to normal individuals, and they see if any other further measures are needed at this point. Now, further measures could include, and we'll talk about them in future videos, they can include medicines, or they can include catheterizations, and in very advanced cases we may have to put a special catheter in and drain the fluid externally, which is not a very easy procedure to do. But paying attention to the urinary symptoms early is important. Also, in male individuals more than female individuals, there are some impotence issues that need to be addressed, and again, those are usually younger individuals that may have problem with erection and impotence, so we have to be addressed with medicines during the visit.
And what about gait disturbances with patients?
Yeah, gait disturbances, of course, from all what I mentioned, if you have a sensory loss, if you have a joint position sense type of loss of feeling where your joints are in space, if you have numbness, if you have motor deficit in the legs, whether it's too little tone or too much tone, that can cause gait disturbance. But also MS can affect the balance part of the brain, so that you can have problems balancing yourself. It can cause visual deficit and double vision, so that yet is another reason to have trouble walking with MS. But walking by itself can be affected in MS. You can have patients who have no tone deficit or have no noticeable sensory deficit or eye deficit, and still they cannot walk very well. There are medicines made to help them walk, and it is sort of vicious cycle sometimes, because it is recommended for patients with MS to maintain optimal weight. And if they are not physically capable of exercising and walking, that can sort of cause them to gain weight, and then becomes a vicious cycle. Because they gain weight, they cannot walk as good as they should be, and that becomes a vicious cycle. So we have to pay attention to walking and use assistive devices if we need to early on, physical therapy, swimming techniques, and any other measure that depending, of course, each case is different. We'll have to target it to the patient, but we have to assist them in maintaining a mobile environment in their lifestyle.
Okay. And would you say patients with MS are more fatigued than normal?
Yeah, fatigue is more and more recognizable nowadays. In the old days, not that long ago, we tended not to think too much of fatigue as an issue, but we started noticing more and more patients complaining of fatigue. Some of them are completely debilitated by it, and some of them have a lot of fatigue without a lot of what's called white matter load. In other words, they can have fatigue without a lot of changes on the MRI to let us think, oh, that person should be fatigued, or the other person should not be fatigued. So fatigue is a very funny thing to try to address, and often we have to use medicines to help with the fatigue, and they may help the depression at the same time because they're stimulants in general. But fatigue can be an issue, and dietary changes and exercise changes that we just talked about can also help with their fatigue. Frequent rests and frequent naps would help, and along with healthy diet and exercise.
And are seizures an issue at all?
In some patients, less than 10%, I think, if I recall the numbers correctly, have a risk of having seizures. And seizures can be a generalized type of seizure where a person would pass out and start shaking, or it can be a partial seizure where one portion of their body will start contracting. But there are also other types of what's called paroxysmal symptoms of MS, which are symptoms that happen not quite a seizure, but like a seizure. There is something called hemifacial spasms, which are spasms in one portion of the face. There are also what's called facial myokymia, which are sudden jerky type movements of the face. Now, these are very common in normal individuals, so anybody who has this doesn't mean that he or she have MS, but it is seen a lot in patients with MS. And there are tonic spasms that actually we see this every now and then, not too commonly, but we see it where the extremity would just go into tonic spasm, usually the arm, but can involve the leg as well. And those are sort of not quite seizures, but they are sudden paroxysmal, we call them, sudden movements that they can experience, and we treat in different ways, of course. Now, if they have the generalized type of seizure, then the neurologist would, of course, consider putting them on seizure medicines in addition to the MS medicines, after doing some studies like an MRI and an EEG. And it is thought generally that patients have a seizure risk because of those plaques or those changes on the MRI of the brain. And some patients are close to the cortex or the surface of the brain, and that is the area that tends to generate seizures because that's where the neurons are. And if those plaques are close to the surface of the brain, then they can induce seizures in some patients. So it's something to also discuss with your doctor if if a person is having sudden movements of the arms or legs, or even episodes of syncope or passing out or generalized seizures, that something has to be brought up to the doctor.
Okay. And is there a cause for patients that have MS for having a lot of pain?
Pain of MS can come from multiple reasons. Generally, it is thought of that MS does not affect the nerves, the peripheral nerves, or nerves of your body, your arms or legs, but it can, of course, affect the optic nerve, as I mentioned earlier. That's a central nervous system type of nerve. So you can have a little bit of pain on eye movement. That's one way to have pain with MS. You can also have what's called trigeminal neuralgia, or an inflammation in the beginning portion of the trigeminal nerve, the nerve that supplies sensation to the face. So that's a very painful disorder. They can have sudden lightning-like pain in the face, usually on one side. It can be both sides. But they can have other kinds of neuralgia, like glossopharyngeal neuralgia, which is a nerve pain that goes down the throat when you swallow, and many other kinds of nerve pain. But they can also have pain that shoots from the neck and back down to the extremity because of involvement of the spinal cord at a certain portion of the spinal cord. And they can also have pain if they have been on steroids for a period of time, as we will talk about later in later videos. Steroids often are used to treat attacks of multiple sclerosis, and use of steroids can cause a disorder in the hip called aseptic necrosis of the hip, and can also cause compressed bones in the back, compressed vertebral bodies, and that can cause pain too. So there are many reasons why a person with MS can have pain, and that should be addressed. And depending on the type of pain, there are neuropathic pain agents that we can use. Those are medicines that we use just for nerve kind of pain, and we of course can address the issue of the pain from bone differently. So we have to try to differentiate on a case-by-case basis as to what's causing that pain.
Okay.
So maybe in next videos we'll talk about the treatment of multiple sclerosis, and what are the things to watch out for and potential side effects of these medications. And if any of your viewers on redradio.us want to follow us, they can log into our website, angelsneuro.com, angelsneuro.com, and they can watch those videos for free and follow us there.
Okay, thank you very much for your time. Until next time.
You're welcome.